Ladies and gentlemen, dear friends, dear colleagues, my name is Carlo Alviggi and I work in the south of Italy in Naples. And I teach in the university reproductive medicine. I'm clinical and scientific responsible of the reproductive endocrinology IVF oncofertility unit of the same university. So it's a pleasure for me to be here today. I won't like to go straight to the point because now we have to move to the clinical practice. Following description by Professor Esteves of the four groups and about the rationale of Poseidon classification, now we have to discuss together how we can apply in the clinical practice the concept that have been pointed out in this kind of stratification. This is my disclosure. But I'm sorry for this because some concepts have been proposed before, but I need to start from the classification again because I would like to propose another angle. Because if we don't understand deeply what is the meaning of the four groups, we cannot discuss the different option for managing these patients in the clinical practice. What is important in the Poseidon classification is that we moved from the concept of poor ovarian response to the idea of low prognosis. The number of eggs retrieved is crucial for prognosis, but it is not the only point. If we want to have an idea about the prognosis of any single patient, we have to take into account other aspects. The first is age and age-related rates of aneuploidies. And this is the reason why the cutoff in the Poseidon classification is 35 years of age, because this is the time where the rate of aneuploidies becomes so relevant in the prognosis of this patient. Another aspect that has been introduced by the Poseidon classification is the idea of ovarian sensitivity to exogenous gonadotropins. For this reason, we have four groups, and please note that group 1 and group 2 have something in common. These groups are represented by patients that at the baseline have a good prognosis because the ovarian reserve is normal. But this patient had, during stimulation, an unexpected suboptimal or poor ovarian response. In brief, they had less follicles than oocytes than expected. Group 3 and Group 4 are more consistent with the classical idea that we have of poor ovarian responders because they are represented by patients that have a low ovarian reserve. So we know that we will not have, during stimulation, more than a given expected number of eggs. On the left side, Group 1 and 3 are represented by patients below 35 years of age. Group 2 and 4 are represented by patients above 35 years of age. So patients of Group 2 and Group 4 have low quantity and low quality of oocyte and embryos. Having this classification in mind, we have to discuss how we can manage these patients in the clinical practice. So Group 1 and Group 2 are patients with apparently normal ovarian reserve that during stimulation have less follicle growing and less oocytes retrieved than expected. So we like to talk about unexpected, impaired hyporesponse. What does hyporesponse mean? So this is an example that has been probably presented before by previous speakers. And this is just to represent that we can have in the clinical practice patients that in terms of demographic, hormonal, and anthropometric characteristics can be comparable. And they could be similar even in terms of ovarian reserve. We can easily see that in these two patients, the antral follicle count was comparable. So let's imagine to start stimulation with a standard dose, which is the same in the two patients, for instance, 150 or 225. In this example, these patients had probably 10, 12 follicle reaching maturity. So the fourth, which is follicle output rate, was 80%. It means that this ovary was very sensitive to the action of gonadotropins. With the same starting dose, this patient only had 5, 6 follicle growing, so probably not more than 5, 6 eggs. In this case, only 30% of the potential of this patient has been recruited and used for ART. So this example is very important because we can understand that in this patient, the stimulation, they gave a normal response, at the least in our opinion. In this patient, the response was suboptimal, meaning that this patient had less than expected and between 4 and 9 eggs. So in this patient, it makes sense in a second stimulation changing something in the protocol. We can do something because we can increase the utilization of her potential. In this patient, probably changing stimulation makes no sense. So this is important for describing the concept of ovarian sensitivity. This is the other indicator that we have suggested. This is the one that we use in the POSEIDON classification, the number of eggs, because the FOI just represents the number of oocytes with respect to the number of antral follicles. For instance, if we have, let's have a look at the case 3, if we have a very good antral follicle count, more than 10, 15 antral follicles, and we only have 5, 6 eggs in this case, we can say that the FOI was below 50%, which is an indicator of reduced sensitivity of the ovary to stimulation. So FORT and FOI are two ways to measure high sensitivity of the ovary to standard stimulation, and they are crucial in our definition of a group 1 and group 2 POSEIDON. So why these patients have an hyperresponse to standard doses of FSH? We don't know it, and this is crucial because if we could understand the reason why, we would have a relevant information for managing in a clinical practice. So we have to start from 3 questions. The first, does hyperresponse, hyposensitivity reflect genetics of gonadotropins and in particular FSH receptor? If yes, can we overcome this problem by increasing the starting dose of FSH? And if yes, is it good to have a higher starting dose in all patients to prevent hyperresponse? And the third question, is there a rule for LH activity for changing, managing hypersensitivity in the clinical practice? I will try in a very synthetic way to give a possible answer to these questions. The relationship between genetics of FSH receptor and ovarian response to exogenous FSH has been analyzed in many trials, basically observational trials, association trials. In this recent meta-analysis, we tried to analyze all the available information. And please note that the sample size that we describe in this meta-analysis is quite relevant. Even 1,500 cases in the arm, for instance, of wild type meaning asparagine carriers. And so let me tell you something. This polymorphism, at the least in heterozygosis, represented by the presence of serine in position 680, is present in even 25% of the population. So it means that 1 out of 4 patients can be carrier at the least in heterozygosis of this polymorphism. And from this meta-analysis, it emerged that the carriers of this polymorphism, serine-serine, in homozygosis during a conventional stimulation has less oocytes than expected, less oocyte when compared with wild-type patients. And another very intriguing concept is that when carriers of serine polymorphism, even when they have a normal number of oocytes, they require a higher dose of FSH. So this is an evidence deriving from association trials, but very consistent trials, describing for the first time that the ovarian sensitivity to a given standard dose of FSH, even in patients with similar ovarian reserve, can be conditioned by genetic characteristic of the receptor. So another question is, if carriers of the serine-serine polymorphism have an ovarian resistance to standard doses of FSH, can we counteract this problem by increasing the starting FSH dose? So we don't have so many trials in this direction, but let me show you just 2 very intriguing evidence in this sense. This is the first attempt that has been proposed by the group of Manuela Simoni some years ago, describing the effect in terms of estradiol production of different polymorphism when patients are treated with exogenous gonotrophins. Patients were stratified according to the presence of the polymorphism serine-serine in homozygosis or wild-type. So please have a look to the left side and right side of the slide. You can see that if we start with 150 international units in both homozygote for polymorphism and homozygote for wild-type, there is a significant difference in terms of estradiol production. With the same dose, the wild-type produce a significantly higher amount of estradiol. But if in the serine-serine patients, we increase of 75 international units, the starting dose of FSH, the estradiol production is comparable with the wild-type group. What does it mean? That these patients have a normal potential, but for having the same ovarian response of wild-type patient needs 75 international more of FSH. There is a similar evidence that has been proposed by the group of Renato Fanchine, and here patients are stratified according to different genotypes, wild-type, heterozygotes or homozygote for polymorphism. And you can see that if the starting dose is very high, meaning 300 international units, all the effect of the polymorphism are counteracted, meaning that the fort is the same in all groups of patients. So, in conclusion, if we have the polymorphism there with a starting dose of 150, we can have a suboptimal hyporesponse in patients with the polymorphism. But starting with the 225 international unit or 300, we can overcome the polymorphism. So the idea from this point of view seems to be, yes, we can overcome by increasing FSH the effect of this polymorphism. So if we start in all patients with 225 or even 300, we will balance the polymorphism. Yes, but there is a problem. And this problem is related with the historical issue of progesterone rise. Let me tell you why. And an example is probably better than any explanation. Let's move to an historical study, which is the famous MERIT study. This is a very nice historical randomized control trial where for the first time the recombinant FSH and highly purified HMG were directly compared, having ongoing pregnancy rate as a primary endpoint, for controlled ovarian stimulation in good prognosis, meaning younger patients. Please note that the trial has been realized with a long-generation agonist protocol. But what is very important is that for both groups, the starting dose was 225. This is very important, 225 international unit. Let's keep in mind this information. So you remember the study, all the endpoints and the life birth for cycles started was comparable in the two groups. So in fresh cycles, no difference between the two gonotrophins. But deeper inside in the results, we have two information that progesterone levels in the recombinant FSH group were significantly higher, and patients with progesterone rise at the end of the stimulation were significantly more in the group of recombinant FSH, even 23%. So let's keep in mind this 23%. So meaning 23% of young patients receiving 225 of recombinant FSH had a progesterone rise. So at that time, this evidence was explained with the idea that the LH activity can probably modulate, can reduce progesterone levels. There is no information deriving from basic science supporting at the moment this hypothesis. But let me tell you something. What has been proven in the last year? That the increase in progesterone level during controlled ovarian stimulation is an FSH-dependent phenomenon, because the production of progesterone is related to the presence of an induction and continuous stimulation of some enzymatic activities that are present in the granulosa cells, and these activities are basically FSH dependent. So the more the FSH, the more the risk of increase in progesterone. The more the granulosa cells, the more the risk of increase in progesterone levels. So progesterone rise is not related to LH. It is related to too much pushing of FSH during stimulation. So when the trial was repeated some years later, the name of the second trial was Megaset. The starting dose of both highly purified and HMG, highly purified HMG and recombinant FSH was 150, 225, 75 international unit less when compared with the previous trial in antagonist environment. And let me tell you, the difference in progesterone rise totally disappeared. So what does it mean? It means that probably in 23-25% of young patients with the good ovarian reserve, starting dose of 225 can be too much. And I cannot, this is just my personal speculation, it's just a working hypothesis, but it's suggestive the correspondence between the incidence in the general population of wild type meaning asparagine genotype of FSH 600 polymorphism, which is perfectly consistent with the incidence of a progesterone rise in young patients stimulated with the 225. To conclude from another angle, I could say that we can overcome the effect of polymorphism by starting in all patients with the 225. But we run the risk of surrestimulation in 20-30% of this good prognosis patient with the exposure to a risk of a progesterone rise. So I think that in the future, we should focus on the idea of personalizing treatment, probably with the use of pharmacogenomics in group 1T Poseidon and in general population, meaning that the starting dose could be 150 or 225 according to polymorphisms of FSH receptor. This is just a working hypothesis that we have to verify by trials in the future. Is there a rule for LH in these women in group 1-2 Poseidon? There are some studies demonstrating that carriers of polymorphism of beta subunit of LH or LH receptor have an ovarian resistance to FSH and require higher doses of FSH, which is perfectly consistent with the definition of hyperresponders in groups 1 and 2 Poseidon. So this is what we have in terms of association studies, but we don't know in the clinical practice, we don't have clinical trials evaluating the effect of LH in carriers of receptor, LH receptor or LH beta unit polymorphism. But we recently proposed a systematic review trying to understand the effect of the association of recombinant FSH and recombinant LH in specific subgroups of low prognosis patients. And in this systematic review, we analyzed studies reporting information about hyperresponders that are perfectly consistent with the definition of group 1 and group 2 Poseidon. And what we found in these trials is that the use of recombinant LH significantly increased the oocyte retrieval and the implantation rate in patients that in the previous cycles or at the beginning of the stimulation showed a higher resistance to standard doses of FSH. We also proposed a meta-analytic approach. Obviously, meta-analyses are not useful sometimes for giving conclusion, but for indicating in which direction we should drive research. So the sample size here is not so high, but the trials are very consistent in terms of results in study design and management of confounders. And what emerged from this meta-analytic approach is that in patients that have ovarian resistance, even young patients, to standard doses of FSH, the use of recombinant LH is more effective than increasing FSH in increasing in the clinical pregnancy rate. So in brief, the association of recombinant FSH and recombinant LH could be useful in patients with hyperresponse to FSH monotherapy. So I would like to move to the second part of my talk, because I want to just to share some ideas on specific subgroups, specific Poseidon groups. The group 2 is represented by patients with a good ovarian reserve that have that are 35 years of age or more. So we don't know what happens in this patient because aging is a very complicated problem. But what is crucial to understand is that when patient overcomes 35 years of age, one of the effects of aging is the impairment, the reduction of androgen concentration in the blood, but what is important in the follicular milieu. So this patient have lower androgens activity. Androgens are crucial for inducing the expression of FSH receptor in granulosa cells. So if androgens are too low, we don't have adequate recruitment. If androgens are too high, as in PCOS, the system is blocked. So androgen have to be in an optimal window. And this window is strictly related to the activity of gonadotrophins and by the activity of LH in particular. So following 35 years of age, we can hypothesize that the system became less sensitive to LH activity. So let's have a look to what Sesh Sunkara proposed recently for the management of Poseidon Group 2. So we can decide if moving from long agonist to antagonist, or we can increase the starting dose of FSH if we're not happy of the result of a previous stimulation in terms of FOI. But one of the options is the addition of LH. Optional, it has to be validated in next trials, but coming back to our systematic review, there is something that is very intriguing, that if we consider all the patients between 35 and 39 years of age, we observe a significant increase in the implantation rate in patients treated with recombinant LH. If you have a look to this initial proposal of meta-analytic approach, we can see that in relatively good sample size, the clinical pregnancy rate was significantly higher in patients aged between 30 and 40 when treated with recombinant LH. What is very important is that if we consider all the trials, including women above 40 years of age, so 42, 43, this effect disappears. So the LH and group 3 POSEIDON seems to be very effective between 35 and 40, but above 40, the effect is less relevant. In my opinion, the explanation for this observation is that above 40, 41 years of age, the rate of aneuploidies is too high and the ovarian reserve becomes too low. What does it mean? That no gonadotrophins, including recombinant LH, can balance, can modify the rate of aneuploidies or increasing the ovarian reserve. So probably some effect of LH is there, but we should have an incredible sample size to have this kind of information. Between 35 and 39, 40, the ovarian reserve is still good. So, and the rate of aneuploidy is still acceptable. So probably LH corrects something different in androgen milieu or in other biological activities of the oocyte, or even has some effect at the endometrial level. We don't know. But there is still place for correcting. There is still place for modify something in these patients. And the reason why I think that the effect, the corrective effect of LH is more evident in this subgroup of patients. What about group 3 and group 4? So these are groups where the ovarian reserve is very low. And so we can try with androgens pretreatment to increase the antral follicular count. We wait for results for understanding if it really works or not. But we cannot create new follicles. So these are low prognosis groups because the number of eggs is very low. But the relevance of POSEIDON classification is that a difference is proposed between patients below 35 years of age and older patients. Because here we have to recognize that the ovarian reserve is very low, but probably the number of eggs we need is not so high because the rate of aneuploidies is very low. In patients of the group 4, we have both problems, few oocytes and very high aneuploidy rates. So in the group of patients where we need more oocyte, we have the lowest ovarian reserve. So it is very difficult to manage this. I don't think that gonotrophins, LH, or analogs regimen can make a so relevant difference. Probably in this group of patients, the accumulation to have the ideal number of oocytes for having at least one euploid blastocyst is the best option. So Professor Ubaldi will talk about this possibility of accumulation, which is called duostim, meaning double stimulation, first stimulation with the generate agonist triggering egg collection. stop 5 days for having the time also to understand how many embryos, how many blastocysts we have. And if the number, we can use a heart calculator for understanding the ideal number of oocytes we need. And if the number of oocytes or the number of blastocysts in 5-6 days is not adequate, we can start in 5 days with the second ovarian stimulation. So having this protocol in mind, this is the first historical paper testing this kind of approach in a trial. And what is relevant in this kind of study is that for the first time, we have two very relevant kinds of information. The first is that even in the same patients, we can have an incredible difference in the ovarian response between follicular and luteal phase. The second is that in terms of blastocyst quality, blastylation rate, and aneuploidy rate, there is no difference between oocyte and embryos and blastocysts deriving from follicular and from luteal phase. So the phase of the cycle that we use for ovarian stimulation is not relevant in terms of oocyte quality. And another intriguing aspect is that if we consider the number of sites, the absolute number of blastocysts, or the probability of producing blastocysts, the luteal phase seems to give significantly better results. And this is another important aspect of dual stim, because having two stimulation, a second stimulation following the first one, there is some increase in the final results. I would like to conclude with these two papers that have been recently published in the members of the POSEIDON group. And the first has been published 1 year ago and is related to suggestion for best practice and also for designing next trials in group 1 and 2 POSEIDON. And it is mentioned that in group 1, increasing the FSH dose and using LH can be a very good option. And in patient above 35 years of age, group 2 POSEIDON, the use of dual stim can even be considered in specific case, but the use of recombinant LH seems to give very good effects. This is another nice another suggestion flow chart that has been proposed by Peter Umaiden 1 year ago. And you can easily understand in this flow chart as dual stim can be a very important options in patients of group 3 and mainly group 4. And in these subgroups of patient, some optimization of the triggering stage with dual or double triggering according, for instance, to Raul-Orvieto protocol can be an option for specific subgroups of patients. So in conclusion, what can we say at the end of this talk? So we need a better stratification of low prognosis women. So the number of eggs retrieved, the ovarian response in terms of quantity is important. But in addition, we need also to consider the age by age specific rate increase in the rate of aneuploidies, and we have to consider the sensitivity of any single patient to standard doses of gonadotropins. Only merging these three aspects, we can have a robust classification system able to personalize clinical management. We have initial information that have to be further tested in next trials, but at this moment we have some information about the management of these different subgroups of patients. For instance, women consistent with the POSEIDON 1-2 groups may be carriers of genetic polymorphism. So this is not the only explanation for hyperresponse. For instance, even pollution could impact on the sensitivity of the ovary to exogenous gonadotropins. But genetic aspects are very promising, and I do think in a next future that probably understanding before treatment the genetic profile of FSH receptor We will distinguish between patients that can have an optimal result with a lower dose and identify patients where higher doses of FSH can be dangerous in terms of risk of progesterone rise. There is good evidence, meaning randomized controlled trials and at least one meta-analysis indicating that in group of hyperresponders consistent with the Poseidon 1 and 2 groups, the LH in particular trials have been performed with recombinant LH supplementation can increase the clinical pregnancy rate and in some trials even the number of mature oocytes obtained at the end of stimulation. And there is good evidence that LH improves ongoing pregnancy rate in women between 35 and 40 years of age who are consistent with the Poseidon 2 and 4 groups. For patients with low ovarian reserve, probably we can try to increase something in the ovarian reserve that we have to induce with the stimulation of antral follicular count by pre-treatment with androgens, but we don't have definitive results in this. What we can do at this moment is that duostim or other systems of accumulation of oocyte or embryos or blastocysts can be an option, and the ART calculator can be a very good way for managing this patient, for projecting the approach, and for counseling, for discussing with the patient what is the ideal number and how to have results with the personalized strategy to be as close as possible to these ideal results. So let me take the opportunity to thank all of you for your attention. And Poseidon is an open community. I do invite all of you to take part of this, to grow together. And I'm really happy to thank all the people working in my unit that supported the trials and all the ideas in the last years, all the international collaborators and friends, mainly in the group Poseidon, and the staff and all the organization, incredible support by Medea in this initiative. So thank you very much for your attention, and we are ready for discussing.